Hello everybody. So we are at the second day of the International COMy Congress held here in Paris. This is the Controversies in Myeloma third International Congress with a special focus on what has been ongoing over the last few months, especially highlights from the International Myeloma Workshop that was held in Delhi. So we had a first exciting day that we summarized yesterday, and actually yesterday evening one important session was the awards session, because as part of this COMy meeting it has become now a tradition to have excellence awards. And we were very fortunate this year to have several applications, and the winners were Professor Dimopoulos from Athens, Greece, and Professor Rajkumar from Mayo Clinic, Rochester, Minnesota in the United States. And both of them delivered key lectures highlighting their great achievements, but most importantly, how the field has moved over the last 15 years. Professor Dimopoulos has an impressive track record of contributions in multiple myeloma, but also in Waldenström disease. And Professor Rajkumar also made seminal contributions, and it was really amazing because both of them not only highlighted the history, the past, where did we come from, but they also nicely speculated on the future and maybe where we will be in 2030 or 2025 in the field of myeloma. And definitely the key word for all this was cure. So great news. And today, Arnon, again, hello, you are my co-chair with Professor Facon. We started very early actually this morning, and the major topic today is actually relapsed myeloma, because obviously the frontline treatment, in my opinion, at least in a European environment, is quite standardized, especially for the young population, going with induction, and it looks like that VRD is really the champion these days, followed by auto-transplant, consolidation, and maintenance with probably lenalidomide. Also, there is some debate whether we should do it 1 year, 2 years, or until progression. But the relapse setting these days is becoming very, very challenging, because actually it's good news, good news for the patient. We have several options, many options, and some people say too many options. I don't believe we have too many options. We need a lot of options. Problem, it's becoming very complicated for the physician. So what are your thoughts from today about the relapse setting? Where do we stand?
I think that the best thing for relapse is to prevent relapse.
Wonderful.
We all know that in oncology, and especially in hematological malignancies, what you are not achieving in the first round, you will never achieve. So I think that I would say that with the new development that we are seeing in myeloma, and we heard about today with the monoclonal antibodies, immunotherapy, and cellular immunotherapy, I think that we should aim the best we can, like we do in other hematological malignancies, to prevent relapse. Because we know that patients that relapse after transplant, especially if it's more than one relapse, the life expectancy is going substantially down, and the chance to cure go substantially down. But this is for the future, and we are not there, and I hope we will be there, but I am not sure. It's very hard to prevent relapse. We know it for other hematological malignancies. And therefore, I think that the approach now not to give one shot or one therapy and one time, but to give long-term therapy for patients with myeloma, with maintenance therapy. There are some people even that give more than 2-3 induction courses now, try to prolong the induction, and then to give maybe 1 or in high risk 2 transplant, and then maintenance therapy, at least for fixed duration and time, and maybe in high risk myeloma that are prone to relapse, maybe triplet therapy, and for continuous time, although it does not prevent relapse. I think that we are making progress even in the relapse patient, but obviously we need to prevent the relapse. I'm not sure it's possible.
Yeah, no, I think we are on the same line. Definitely we need to prevent relapse. However, I believe, and I hope you agree with me, that we need to be pragmatic. So majority of myeloma patients will relapse these days. When I look to what we heard today, the landscape is actually becoming more and more structured, and things are becoming more and more refined. So when I look to the IMiDs, we had, I would say, the grandfather, thalidomide, we had the father, lenalidomide, and now we have the son, pomalidomide, new generation. When we look to the proteasome inhibitors, again, the situation is very clear. First in class, bortezomib, first generation. Now we have second generation, carfilzomib, ixazomib. Then when I look to a new family, monoclonal antibodies, I think we had a very nice reminder this morning that at least 12 different monoclonal antibodies were tested in myeloma and failed. And now, in less than 2 years, we have 2 monoclonal antibodies which are proving to be effective. Daratumumab, the anti-CD38, already approved. Elotuzumab, targeting SLAM-F7. And under development, we do have isatuximab, anti-CD38, but also the more FOSIS 202, which also targeting CD38. And of course, we do have the HDAC inhibitors, vorinostat, which actually wasn't approved, and panobinostat, but the efficacy of HDAC inhibitors is viewed to be less important than other drugs. So here I think we do have these families with different mechanism of action. In my opinion today, I think we got the approval, they are available. The challenge is how are we going to sequence them? And in my opinion, and I'd like to hear your opinion, now that we have these trials, it's okay. For me now the next the next step is we need to take very concrete scenario of real life situation and then try to figure out what would be the right relapse therapy. So if you have first generation proteasome inhibitors, first line auto transplant, what are we going to give at time of relapse? If you have IMiDs frontline for 2 or 3 years, what are you going to give that relapse and so on? So what are your views?
So I think that we are beginning to dissect this situation, and there are some rules that we all are using now. So for instance, that start with Velcade or proteasome inhibitor-based therapy upfront, and he then relapse. We are not talking about chemical relapse, but overt relapse. We will give him Revlimid-based therapy. And the one that starts with RVD, we will give him a next generation proteasome inhibitor-based therapy. Of course, the monoclonal antibody, I think that this is the beginning of immunotherapy, which we all believe in it, getting into myeloma. And I believe that maybe the monoclonal antibody, which are now approved only for second and third line therapy, even fourth line for daratumumab, will came up front. The question will be if they will be used up front, so it will be difficult maybe to use them in relapsing a patient, but again, I don't think that we need to save drugs for the relapsing patient, but we need to give them initially when there is no such aggressive or malignant clone and the chance that they cure the patient. So I think for sure for patients with relapse, which considered to be anyway high risk because the clonal evolution, we should give the best drugs that we have, taking into consideration what the patient got initially and also the performance on the patient and trying really to see that we can give, at least in relapse, the best package that we have, that the patient will not have additional relapse, because we know that the third relapse, the life expectancy of the patient is few months, 6 months or something like that.
So speaking about relapse, aggressiveness, high risk and ultra high risk, actually we heard a wonderful overview and lecture by Dr. Usmani about plasma cell leukemia. And we know this is really a desperate situation. And I liked the presentation by Dr. Usmani, which was very straightforward, giving us a clear algorithm at the end how to tackle plasma cell leukemia. Put the best drugs, the best combinations you have for induction, including conventional chemotherapy whenever feasible, then go to auto and eventually allo. And you yourself also address the role of allo in general in myeloma. Do you agree on this algorithm?
Yeah, I think that plasma cell leukemia, but he rightly broadened the spectrum for high-risk leukemia. I think this is leukemia.
High-risk myeloma.
High-risk myeloma. And I think that these are devastating diseases that we really need to invest on them. Usually when we get a patient like this, it's very hard to discuss the prognosis with the patient and the family. I was thrilled by his talk and by the future studies that they are designing, are going to do, incorporating, the Revlimid-based therapy and monoclonal antibody and the maintenance therapy to this patient, including prevention for CNS relapse. And I think that this is just illustration that we can make some progress, even the most devastating disease. Of course, the challenge there is very high.
Yeah, absolutely. And last but not least, today, and this is part of the closure of this meeting, we had the Lifetime Achievement Award to Professor Ken Anderson. And I think we as organizers of COMy, we are really honored and we feel privileged having Professor Anderson with us. I think without any doubt, Ken Anderson can be considered as, I would say, the father of modern myeloma therapy. He has been pioneering all the advances in the field of myeloma, and it is really amazing to see his contributions, his dedication, and the whole myeloma community here during COMy was very, very grateful to his talk, which gave us not only a historical overview, but also planning for the future. I think the future is really brilliant.
Yeah, I think that we called it the Mecca of myeloma. It's not just him, but the students of him.
Of course, he has students all over the place, all over the world.
The head of the program in myeloma that he raised, and we had also from his team, Professor Paul Richardson and Nikhil Munshi. So I think that this is one of the top, if not the top place in the world. And the fact that he's honoring the COMy meeting and the patient advocate, and did all of this far away traveling for giving a talk, it's really fascinating, and to the really prestigious for the COMy meeting is really becoming, as many people say, a real event in the myeloma field.
Actually, as part of the COMy educational events and initiatives. We will be launching soon the Virtual Academy of Multiple Myeloma. Here we will really initiate a new era in terms of knowledge dissemination in the field of myeloma and plasma cell dyscrasia. So please watch out for the launch of the Virtual Academy of Myeloma, VA Myeloma, because it will be an amazing new tool towards exchanging experience, exchanging knowledge, and disseminating information for the benefit of the scientific medical community, but also for the benefit of patients worldwide.
And I think it's extremely important because the meeting is like induction or consolidation, so it's concise for 2 days. The academy and the virtual office is a maintenance therapy. So exchange of ideas, long-lasting, in which you can get in and out and see what is on in vivo, daily, what is happening. So I think it's a very, very important tool for us and for the community and for the patient to have more progress and to cure this devastating disease.
So definitely the efforts will continue, and we would like to ask everybody to book your agendas for COMy 2018 very soon. Thank you very much.
Thank you.